welcome to this lecture over pulmonary anatomy and physiology basics. This lecture is intended for that pre-matriculation student, like a pre-PA student or someone that has just been accepted into a PA program, so that you can brush up on those basics of pulmonary anatomy and physiology, so that when you get into the pathophysiology and the graduate level anatomy, you know what you're getting into and you can really push to succeed. Okay, my name is Prof G and I am a clinical assistant professor and I am here to take you through this lecture today. So before we dive in, you might be wondering, why is Prof G an expert and able to teach us about this stuff? Well, I'll say this: I am not an anatomist, I am not a physiologist, I am a PA. And I think this perspective on basics of anatomy and physiology is a good one for us because I can give you kind of a clinical tie-in to what we're learning. I'm not going to get down and dirty with all the details. I'm going to keep it simple and try to just get us to learn the basics so that when we get into PA school, we can hit the ground running. So I'm originally from Edinburgh, Texas, which is in deep South Texas along the border. I went to high school here and then went off to undergrad at Southwestern University in Georgetown, Texas, where I played Division III soccer. After that, I graduated undergrad, and in 2 weeks later, I started PA school at UT Southwestern in Dallas, Texas, and I was the youngest of my class. I graduated PA school in 2007, and after that, I started right away in emergency medicine. I got a job based on the rotation that I did in emergency medicine. For the past 15 years, I've practiced primarily in emergency medicine. I did 1 year in clinic gastroenterology, and now I'm currently doing some pediatric telehealth and urgent care. So I have about 15 years of experience, a few different specialties, and I have been with University of Texas, Rio Grande Valley since 2017, teaching there at the PA program. And a few of the courses I teach the Intro to Clinical Medicine course for the didactic students. I teach the pulmonary module, the GI module, and the EENT module, and I also coordinate this course. I teach some anatomy, I do some guest lectures, and I teach anatomy lab where we get into the cadaver lab. It's one of my favorite things as a professor. I've also taught some patient encounter lab and clinical clerkship. I'm the director for that this year. All right, so with everything that we do in PA school, we try to have a clinical minded approach to it, because patient's not going to come in and ask you, what are the respiratory zones in my body? No, they're going to come in with a cough, and you're going to have to use your problem solving skills and your previous knowledge of anatomy and physiology, put those pieces together to diagnose them and treat them. And so for this lecture, I wanted to start out with a case briefly. Now this case, we're not going to cover just yet. We're just going to introduce it, and then later on in the lecture, we will go through this case together and try to come up with the correct answers. So we have this young man. He is a 9-year-old kiddo. He has a history of asthma, and he comes in with wheezing and shortness of breath. He also has a fever of 102, and he is throwing up. And on examination, he has some lung sounds like wheezing and rhonchi. If you don't know what wheezing and rhonchi are, I would recommend you go and listen to some YouTube videos and you can learn a little more about that. We hear those abnormal breath sounds in the right lower lung field. So we have some questions here. We're not going to go through them just yet, but we'll get to them after this lecture. Keep this little clinical vignette in mind as we go through this lecture, and I'll try to kind of chime in on it as we go along. Now, you might be thinking, what is the importance of the respiratory system? What does it have to do besides breathing, right? What does it have to do, and how does it help the human body? Well, there's some out there that would say that the cardiovascular system, the heart, is the most important system in the human body because it pumps the blood around. Without the heart, we wouldn't have anything, right? And then there's some that say, well, I argue with that. I say that the brain is the most important organ in the human body, and that the neurological system is most important. And then there's folks like me who are trying to propose somewhat of an argument that the respiratory system is equally as important as any other system in the human body for maintaining homeostasis. And so a few reasons why I think the respiratory system is so important is the first one that we all know. It is the primary function is breathing, right? Taking in oxygen, which we use in cellular respiration for all the cells in our body, and then removing carbon dioxide, right, as a waste product. Now, this is what I think of when I think of the respiratory system. But there are a lot of other processes to sustaining life that the respiratory system plays a role in. One of which is the acid-base balance system. So within our body, we have a pH, and we have several different processes that help us to regulate pH, and breathing is one of them. Now, CO2 or carbon dioxide is an acid. And so by controlling the rate of breathing, we can change the pH in the human body by blowing off more CO2 or retaining CO2 by breathing more slowly. So that's something we don't often think of. It is something that plays a role in acid-base balance. Something else, I've been talking this whole time, right? We've had vocalization. It's a very important part of the respiratory system. The way that the anatomy is constructed within our upper respiratory system helps us conduct and vocalize and amplify for speech production and vocal amplification. A couple other things. Regulating water balance. As we breathe, our airway is humidified, so breathing more, we can lose water vapor, and that can regulate water balance. There's also defense against pathogens. So we know the minute we get a cold, the first thing that comes are the boogers, right? We get boogers all in our nose. We start coughing up boogers, and these mucus production and the type of cells that are within our airway help us defend against these pathogens. We also, something else we don't often think of is it helps with venous return to the heart. So the way that the pressures are within the lung cavity create negative intrathoracic pressure, which pulls that venous return back up and into the heart, which is something we don't often think about. Another thing the respiratory system plays a role in is olfaction. Now, which cranial nerve is responsible for olfaction? Maybe you know it. It is cranial nerve number 1, the olfactory nerve. And the olfactory nerve, along with the nose, is the way that we smell. Okay. And last but not least, our respiratory system does play a role in thermoregulation and vasoconstriction. Basically, when we go into either fight or flight mode or rest and digest mode, we retain heat and we can dissipate heat, or we can vasoconstrict and vasodilate. And that plays a role in it as well. So as you can see, there are a lot of things the respiratory does other than just breathing. All right, so we're going to try to keep it simple going into the anatomy and physiology, starting with basic structure and function. How does the structure work, and how does that relate to function? Now, the overview to the respiratory system, essentially with functional anatomy, we have 2 major categories of functional anatomy: the conducting zone and the respiratory zone. Now, the conducting zone, just like a conductor in an orchestra, is the portion of the respiratory system which guides the air down and into the lungs so that we can take it to the respiratory zone where the magic happens, okay? Now, parts of the conducting zone are typically rigid conduits, have cartilaginous aspects to them, and they help the air reach the site of gas exchange. So these are things like the nose, the nasal cavity, the pharynx, larynx, trachea, and bronchi. And as you can see, we have cartilage up here in the nose, we have cartilage down here in the airway, and we have these cartilaginous rings along the trachea. What do you think that these cartilage rings are good for? What is their purpose? Well, if you said to protect the airway and to help keep it open, you are correct, okay? So let's imagine something. Let's imagine we're at our favorite restaurant and we just ordered a milkshake. It comes to our table, we stick our straw in there, and we go for a big slurp, and nothing comes out, right? Nothing comes out because the straw collapses, and it takes a little bit for that milkshake to kind of melt before we can actually, suck it up and digest it, right? So imagine that happening in the airway. That would be really bad, right? We take in a big inspiration of air, and our airway closes off, right? That would not be a good thing. So our body has cartilaginous rings around the major airways to help fight that resistance and help fight those pressures and keep the airway open. Okay, and that is one of the important functional components of the conducting zone. Now, after the conducting zone, we have the respiratory zone, and like I said, that is where the magic happens. This is where respiration or inspiration, oxygen, gas exchange, where that happens is the site of gas exchange. And there's two major areas that are part of the respiratory zone. We have the respiratory bronchioles, which are some of the terminal airways that have little alveoli branching off of them. And we also have the alveolar ducts, which we'll get into a little more coming up. Now, this little chart I adapted from one of my favorite YouTubers, Medicosis Perfectionalis, so that we could see in one chart the comparison between the conducting zone and the respiratory zone. So a few highlights from this chart. The conducting zone is also known as dead space because it's an area where air is in, but it's not an area where a gas exchange occurs. So like we said, anatomically, from the tip of the nose down to the terminal bronchioles, and then the respiratory bronchioles to the alveoli or the respiratory, you can look here at the different types of structures and cells which are found in each one, and then the blood supply to each one, the whether or not gas exchange occurs there, which we just talked about, and then the functions of it. What does it do? Well, the nose and upper airways helps warm and humidify air, which makes it easier for gas exchange. And then we also have the defensive components to help out up there, like the mucus, one of my favorite terms, the mucus escalator, which is comprised of the cilia that help carry up pathogens and mucus up and out of the airways. And then specialized cells that help us break down pathogens called macrophages. On the respiratory side, it's less about defense and less about humidifying and more about gas exchange. So we have different types of cells. We have the type 1 pneumocytes, which are the thin cells where gas exchange takes place. We also have type 2, which are the important cells for creating or making surfactant. And then we also have some more macrophages down there, aka the dust cells. So let's take a little journey starting from the upper respiratory tract and make our way down to the lower respiratory tract. As we know, up high in the respiratory tract, we have the nose. Now, I think everyone knows what the nose does. It's important for olfaction, but it also helps moisten and warm the air and helps us filter the air that we breathe in. And that's important because we want to minimize pathogens reaching our lower airways and our lower respiratory tract. And we can more easily have gas exchange with the moist, warm air. Now, in addition to the nose, we have the paranasal sinuses, which are air-filled areas of bone in the head area, which help also warm and moisten air. They're also resonating chambers for voice amplification. So as the air passes through them when we're speaking, it helps us amplify our voice. That's why when we get a sinus infection or we get our sinuses clogged up, our voice tends to be softer or it doesn't carry as well. Now we have several different paranasal sinuses. We have the frontal sinus, which is kind of in the forehead area. We have the sphenoid and ethmoid sinuses, which are deeper within the skull. And then we have the maxillary sinus, which is the biggest sinus. We have those on either cheek area. Moving down, we have the pharynx. The pharynx connects the nasal cavity to the larynx and esophagus, right? So it's that area in the back of our throat, a throat area. It's a area where it's kind of a shared space, right? So it's a common pathway for both air and food. So we have a structure, anatomy in place to help us be the gatekeeper between the airway and the esophagus, including the soft palate and the epiglottis. We also have the nasopharynx, which is up high. We have the oropharynx and the laryngopharynx. And we have the larynx, which is kind of the area where the voice box is. Moving down to the lower respiratory tract, we have the trachea, aka the windpipe. This is the area that has the widest diameter, and it has cartilaginous rings for the stability. We then break down into the right and left primary bronchi as the trachea splits. And these two bronchi, the right goes to the right lung, the left goes to the left lung. Those are considered the primary bronchi. Then the primary bronchi branch, kind of like a tree, right? We start for the trunk and then branch. So the primary bronchi break off into secondary bronchi, which are also called lobar bronchi. So we will have 3 on the right and 2 on the left. And that is because we have 3 lobes on the right lung and 2 on the left. Can you think of any reason why we would only have 2 on the left and not 3? Well, yeah, you're correct. We have a heart on this side that kind of favors the left side. So we have to kind of make room and space for that. So we had to cut out one of the lobes on the left side, at least when we were being created. So the heart fits in that area, and that's why we only have 2 on the left and 3 on the right. So the secondary bronchi are lobar bronchi. Each one will supply a lobe of the lung. Now those secondary bronchi branch again into tertiary or segmental bronchi. And you can further subdivide the lungs into segments. And I didn't do that on this slide, but there are different segments, and each one is supplied by a segmental or tertiary bronchi, which is important. Let's say if we needed to remove part of the lung, we would know that we could take a segment of the lung out without affecting the other segments within the lung. And then they branch again and again and again until they become bronchioles. Now, some bronchioles are considered part of the conducting respiratory system, and there are some, the respiratory ones, that are considered part of the respiratory system. Bronchioles are really tiny little airways, and they're under 1 millimeter of diameter. And then the terminal bronchioles are less than that. And then respiratory bronchioles, which are the first part of the respiratory zone, are the smallest in the area right by the alveoli. There's another little area here called the carina, which I always remember because it looks kind of like a backwards, upside down heart. That's the area where the trachea splits here. And cariño is another word for like love or caring. And so that's how I remember that it is the carina in that area. Now, the lower respiratory tract continued in this slide are going to be the respiratory areas. So we have the respiratory bronchioles, which are essentially little bronchioles here that have alveoli kind of branching off of them. And then we have the alveoli. The alveoli are the little grape-like sacs where oxygen and carbon dioxide gas exchange happens. And there are over 300 million alveoli in our body. So the alveoli are subdivided into these little clusters look like grapes almost. And each one has its own little lining on the inside. And that is to increase the surface area. The more surface area you have for gas exchange, the more areas you have for gas exchange, and the better we're going to be able to transfer oxygen and carbon dioxide. They say that if you took each one of these little alveolar sacs and you spread them out over, a flat surface, it would essentially approximate to about the length of a tennis court. So we have a lot of area for gas exchange, which is pretty cool. There are, within the alveoli, we have the air blood barrier, or the alveolar capillary membrane, and this is the area where gas exchange occurs. There are networks of alveoli spread out throughout the lungs, and they have different types of cells in place to do different jobs throughout. So we have, again, the type 1 pneumocytes. These are the flat single cell layer areas where gas exchange happens. We have some type 2 pneumocytes, which are the ones that produce surfactant. We have some capillary endothelium. We have the basement membrane. We have interstitial space. And then we have the alveolar macrophages and essentially some elastic fibers. Important thing about surfactant. What is surfactant good for? Okay, it has the word surface in it, kind of. Surfac, right? Surface. So surface tension. Surface tension is a principle of physics, which I'm not a physicist by any means, but we want to decrease surface tension within the alveoli, because the tendency for the lungs is to recoil because it has these elastic fibers in, similar to a balloon. So say you blow up a balloon and you left it open. Would it stay open or would it recoil? Well, a balloon will recoil because the tendency of the elasticity in the balloon is for it to recoil. Now, that would be bad if these little alveolar sacs, every time we breathe out, were to collapse. That would be bad because it would take a lot more force to open it back up. And so what the type 2 pneumocytes do is produce surfactant. And what surfactant does is it decreases the surface tension within each of the alveoli to keep it open in between breaths. Here's some other diagrams kind of showing you the different generations of the airways. And I'm not going to go through it again, but you can kind of see the difference and how they branch off. And yet another depiction here. So we talked about kind of the inner pathways of the lungs, but the anatomy of the chest wall is also important because the chest wall itself is kind of what helps us to open and to breathe, essentially. And we have to have some integrity, some structure to protect those lungs underneath. So we have some bones that make up the chest wall. As you can see here, the ribs play an important part in the chest cavity, the chest wall. We also have the sternum, which has the manubrium, the sternum, and the xiphoid process. We also have the two collarbones, which help out, and we have the vertebrae in the back of this, the vertebrae that connect the ribs from the sternum backwards. We also have some important muscles in play. We have the intercostal. Costal are ribs. Inter in between. So we have intercostal muscles between the ribs, which help open them up. And then and also to forcefully exhale if needed. And then we have arguably the most important muscle in the respiratory system. This is the diaphragm. The diaphragm is our major respiratory muscle, and we use it with every breath that we take. Now, joints, each of these bones is connected to another, and there's joints there that help facilitate movement, like the costovertebral joints, the costochondral, and the sternocostal. We need movement there so that the chest can expand and deflate. Getting a little deeper, hugging that chest wall, we have pleural coverings that cover the lungs and the inner chest wall. And it's a double layered pleural covering. So there is an external layer, which is the parietal layer, and we have the layer that hugs the surface of the lungs, which is the visceral layer. So these pleural coverings help with reducing friction and facilitating lung movement when you're breathing, right? We want those lungs to smoothly expand and contract, right? We want that to happen seamlessly. We don't want any resistance. The parietal pleura, parietal comes from the word pared, right? Wall, meaning wall. So it hugs the chest wall. Okay, and that is this outer layer here. And then we have the visceral pleura. Viscera are our organs, so the visceral pleura hugs the lungs, covers the surface of the lungs. Now, the space between the two layers is the pleural cavity. And there's a little bit of liquid that occupies this space, but generally speaking, these two areas are under negative pressure, and so they tightly adhere to one another within the chest cavity. They stay close. And so I put this little picture here to try to help us understand how the lungs kind of stay open and how the chest wall and the pleura kind of work against each other to create a negative pressure. So the lung at rest, the tendency of the ribs is for the chest wall to be pulled outward. And the tendency of the lungs, like we said before with the elastic that we have, is for that to have elastic recoil going this way. And when you have two opposing forces working against each other, it creates a negative pressure. And a negative pressure pulls. And the negative pressure keeps this lung open. And that's really important because we talk about different pathologic processes like, say, a pneumothorax or a tension pneumothorax, which work against these forces that are the natural forces within the chest cavity. Here's a nice little med comic about a tension pneumothorax. You can see that there is a penetrating trauma to the chest, and that disrupts the negative pressure, causing the lung to collapse and kind of go towards the side. It's called deviation. And many other things happen when homeostasis is abruptly disrupted. All right, so we started talking about this in the previous slide about pressures. Now, we're not going to go into all of the physics, the Fick's law, the Dalton's law, Henry's law, but we are going to cover just a little bit of physics, and we're going to cover Boyle's law because I feel like that's a nice basic one that we can understand, okay? Now, the mechanics of breathing, we have inspiration, which is drawing air in, and expiration, breathing air out, okay? These two forces are different from one another. We'll kind of compare and contrast them over the next couple of slides. So, when we inspire, when we take air in, what happens is a change in pressure within the interthoracic cavity, okay? So the diaphragm contracts and pulls downward. The external intercostal muscles contract and pull the chest wall up and out. And what that does is it creates a negative pressure within the lung cavity. How do I know it creates a negative pressure? Well, Boyle's law helps me. We have an increased volume. As the chest cavity gets bigger, we have a decreased pressure. Our pressure lowers. And when we have a lower pressure, negative pressure pulls. So it pulls in air into the lungs. Okay, that's inspiration. Now, that is an active process. We have two muscles that are actively contracting to make that process happen. Now, expiration is a passive process. Basically, the muscles are just relaxing. Okay, so we get relaxation of the external intercostal, we get relaxation of the diaphragm, and like we said earlier, the lungs in a natural state have elastic recoil that bring them back to baseline. And so if these muscles are relaxing, the volume within the lung, it gets smaller, okay? And if we have a decrease in volume, we have an increase in pressure. And the increase in pressure pushes. Positive pressure pushes. So that will push the air back out. Does that make sense? I hope it does. Makes sense to me. And so Boyle's law is essentially saying that when you have an increased volume, your pressures decrease, and your volume is low, your pressure is high. It's an inverse relationship, and this is all taking into account that the temperature is remaining constant, which is one of the principles of the law in physics. So hopefully that makes sense. If that diagram didn't make sense, there's a nice little chart here to help us sum it up. So like we said, inspiration is an active process. We have two muscles involved. We have the diaphragm and the external intercostals, which help open the lung area. We have increased volume, Oops, that was a bad arrow up. Increased volume. And so with increased volume, according to Boyle's law, causes a decreased pressure. And we said that negative pressure pulls air into the lungs. That's inspiration, okay? Now this process, because it's an active process, is shorter. It takes less time to inspire than it does to expire. This is during quiet, normal, active, quiet breathing, okay? Not during when we're sick and we're having to breathe forcefully. During forced inspiration, we have even more muscles that are involved. They're accessory muscles, like the SCM, the serratus anterior, and the scalene muscles. And when we have patients that are working to breathe, say having an asthma exacerbation, like our patient at the beginning, we can have accessory muscles, other muscles become involved in the process to try to help open up the lungs, okay? Now, expiration, we said, was a passive process. The lung, nothing is contracting, everything is just relaxing. And so because it's not active, it's passive, it takes longer to happen, okay? So we have a short inspiration and then, okay, that's the inspiration, expiration. Remember that Boyle's law says we have a decreased volume as everything relaxes. So that means we have an increased pressure, and the increased pressure pushes the air up and out of the lungs. Remember, this is a passive process, so everything is just kind of shrinking back by elastic recoil. And then under forced expiration, say for instance when we're playing a musical instrument, when we're coughing or trying to breathe out against an obstructive process like COPD, we're going to involve the internal intercostals and maybe some of the abdominal muscles. All right, so now let's talk about respiration, okay? We basically have two types of respiration. We have what's called external respiration, and we have internal respiration. Well, first let's talk about external respiration. We have essentially three components to external respiration. We have ventilation, which is the process of bringing air in through the upper airways, down and into the lungs. Basically the process of bringing air to the alveoli and taking the air back out of the lungs. That's ventilation. We have diffusion, which is the process of moving the gases from the alveoli and into the blood. Okay, that's moving it out of the respiratory membrane. And then we have perfusion. Perfusion is the blood flow that's coming to that area to receive that oxygen and to give back that carbon dioxide. That's perfusion. And so that's circulation and distribution of blood to the capillary bed. Now, those are the three processes of external respiration. Internal respiration is pretty simple. It's at the cellular level. After this blood picks up the oxygen, it takes it to the tissue, then there's another exchange that happens between the capillaries there and the cells themselves with the mitochondria, and that's where you get cellular respiration, okay? That has to do with mitochondria and oxygen and ATP and all that good stuff. So we have the three components: ventilation, diffusion, and perfusion, and then we have cellular respiration. Now, if you have a problem with any of these processes, you can get hypoxia. Hypoxia is you have not enough oxygen within the blood, okay? Hypoxia. And any one of these three processes can cause hypoxia. Any problem with any of these can cause that. And so, can we think of maybe one disease process that would disrupt ventilation, getting the air into the lungs? Can you think of anything? Well, I think of our little patient, our little 9-year-old patient. He has asthma. Asthma causes a narrowing of the airways, okay, and also some mucus production here. So there is decreased passageway for air to get to the alveoli. That is a disruption of ventilation. Now, diffusion, problems with diffusion, you can have certain diseases where you get fibrosis or scarring within here, and you can get a less permeable area for gas exchange for diffusion. That can disrupt that. And then perfusion, I can think of two things. I can think of maybe anemia, where you don't have as many cells to carry the oxygen. Or you can have a blood clot, like a pulmonary embolism, that's blocking blood flow to certain parts of the lung. Now, if you could recall your cardiovascular system, we know that the circulation of the heart is integrated with the circulation of the lungs. We say that the right side of the heart is going to pump this blue deoxygenated blood out of the pulmonary trunk, and from the pulmonary trunk is going to carry that deoxygenated blood via the pulmonary arteries to the lungs that go to the capillary beds. And these capillary beds are surrounding the alveoli, and this is where gas exchange occurs. Then the pulmonary veins in red here are going to bring the oxygenated blood back to the left atrium. And then they're going to go to the left ventricle and out via the aorta to be carried to the body. Okay, so this is considered the pulmonary circulation. This is the way that the blood flows through. Now, something that's a little bit different in pulmonary circulation is that the pulmonary arteries are carrying deoxygenated blood and the pulmonary veins are carrying oxygenated blood, which is different than any other place in the body, minus the umbilical artery if you're pregnant. Okay, and this is really important in homeostasis. Okay, now there are other arteries called the bronchial arteries, which come directly from the aorta carrying oxygenated blood that supply the lung tissue itself. So it supplies the lung tissue. The only thing that these bronchial arteries do not supply are the alveoli. The alveoli receive their oxygenation from the pulmonary circulation. Now, a little earlier we talked about the area of gas exchange at the alveolar capillary area, and this is the area where gas exchange takes place. We have oxygen coming through, we have carbon dioxide coming out. You can see it's a very thin single layer of cells, and some other really small thin areas like the epithelium and the endothelium and the basement membrane in here, interstitial space. It's a very short distance for gas exchange to happen, which is good for our body. Last but not least, we're going to briefly talk about the pulmonary nervous system. So essentially, like we've said, we've been breathing this whole time we've been listening to this lecture, right? We've been breathing in, breathing out under autonomic control, which is good, right? It would really be taxing for us to have to breathe and think about every single breath we take. It would distract us a lot from other things that we're trying to do. So most of the time breathing is under autonomic control, and it's controlled up here in the medulla oblongata. Autonomic system is a balanced system between sympathetic, which is the fight or flight mode, and the parasympathetic, which is considered like the rest and digest mode. Essentially, the sympathetic system, if it gets kicked in, causes vasoconstriction, because blood is getting shunted to other things like the muscles, right? And to run away. And then we have bronchodilation to help facilitate air getting into the alveoli so we can breathe to run away. Then we have parasympathetic. That's when we're chilling, okay? And this, when we go into that mode, we have a little bit of vasodilation, which makes it easier for blood to get to the alveoli. And then we have bronchoconstriction because we don't need our airways that wide open for just normal quiet breathing. And then we also can override our breathing, right? I can tell you, hold your breath. And we hold our breath, right? Now, the somatic system can override the autonomic control via skeletal muscle and the diaphragm. Now, let's relate this clinically, right? So when we have bronchoconstriction, we can have problems with the airway closing off when we don't want it to, like in asthma. And what we do essentially is we prescribe medications for asthma aimed at mimicking this sympathetic response, aimed at mimicking this bronchodilation. We give beta agonists, right? We give these sympathetic type, sympathomimetic type medications, which is kind of cool. That being said, let's get back to our case, okay? So we said we had a 9-year-old, history of asthma. He has a fever, he's throwing up, he's short of breath and has wheezing, and on exam you hear some wheezing and some bronchi. And it is more so in the right lower lung field. So a differential diagnosis is kind of a short little list of things that we think that could be the etiology of the patient's problem. Now, we'll go more into building a differential diagnosis and such in our courses, but for the sake of this, what are some things you think this kid could have? Well, we know for sure he has asthma, okay? So that could be something. It could be an exacerbation of his asthma. He has a fever, which we usually don't see with asthma, so we're thinking he could have some sort of little infection. There's things like upper respiratory infections, pharyngitis, other things. But with the bronchi and it being in one little area of the lungs, I'm thinking pneumonia with asthma, okay? Why is he having the wheezing on this side of the chest? Well, I can think of one other thing in a younger kid. An obstructive process like maybe aspirating something could block off part of the lung, and that could cause a problem on one side of the chest. Why he's having wheezing on one side of the chest and bronchi could be contributed to by pneumonia. Okay. What other abnormal vital signs would you expect? Well, we have 5 vital signs, right? We have blood pressure. Okay, blood pressure. We have pulse. We have respirations. We have temperature. And we have urine output, which we don't usually consider the 5th vital sign. We usually use pulse oximetry or pain as the 5th and 6th vital sign. So we don't have a blood pressure here. I would expect it'd probably be pretty normal. The pulse, we have a fever. The body's under a little bit of stress, so I would imagine that his pulse is probably going to be up a bit. And also he's having a little bit of work of breathing. He's short of breath. So I would also anticipate that his respirations might be up a bit. Now we already know his temperature is up. What would we expect his oxygen saturation to be? Maybe down a little bit, okay? And then would we admit this patient to the hospital? That's a little tough to say. We have a patient that's having asthma, having shortness of breath, work of breathing. We don't have quite enough information to decide if he needs to be admitted to the hospital, but given that he has a lobar consolidation, or we think he might have one, and he has a history of asthma, he'd be one that we'd have to be really careful with and possibly admit to the hospital. All right, so this takes us full circle with our anatomy. We're not going to learn how to read x-rays in a few minutes, but we can definitely tell this is a picture of a chest x-ray. We'll be covering some more radiology later on in different lectures. You can see here that normal air spaces is going to be this dark color. This is air, okay? You can see there's little lung markings in here. Those are normal. But we should be seeing this air all throughout the lung field. But you see here, there's an area here that doesn't have that air. It has what we call consolidation. It's consolidated. There's something more dense occupying that space than air. So that's worrisome. And it's on the right side. And that is where we heard that wheezing and bronchi in our patient. So if we overlay this picture that we saw way at the beginning of our lecture, we noticed that the area of consolidation The area of consolidation is in this area. And what lobe is that? Well, this is the right upper, this is the right middle, this is the right lower lobe. So we know that this kid has a consolidation in the right middle lobe, which looks like pneumonia. And so you can see how important it is to understand the basic anatomy and physiology of the lungs, to understand what this patient has, why it's causing the problems that it's causing, and how it's affecting our patient. And so with that being said, we are done with this lecture. Hopefully we picked up a few things, some of the basics of respiration, internal and external respiration. We learned a little bit about the upper and lower airways, the conducting zone, respiratory zone. We learned a little bit about inspiration, expiration. We even learned a little bit about Boyle's law. We got a little physics going on here. And so we put all those pieces together. We were able to better digest, better dissect our case that we saw at the beginning and then again at the end. There's more to come with respiratory medicine. And if you're interested in getting ahead and looking at some of the respiratory lectures, I have an entire series of respiratory lectures covering the PANTS, the test for PAs, the blueprint, and you can go lecture by lecture and cover the blueprint there. I'll link that in the description. I'll also put a little box here so you can easily access that playlist. Like always, it's always a pleasure to lecture and to give you a little bit of insight. I'm Prof G, and thank you for listening, and I will see you soon.